Welcome to Plenary 3. This plenary is titled Striving for Universal Health Coverage. In this plenary, we shall hear 3 presentations. One will focus on the role of nurses in universal health coverage. The other presentation will focus and look at access gaps to care. And a third presentation will be a personal story around living with a chronic disease. That will be followed by a moderated panel discussion. We thank you for joining this session. We hope you'll enjoy. Welcome.
Greetings. I am pleased to address this 51st Union World Conference on Lung Health in 2020 and to speak about the important roles of nurses and healthcare workers to address tuberculosis, lung diseases and COVID-19 and contribute to achieving universal health coverage. As the COVID-19 pandemic progresses, the importance of scientific and applied research to improve the treatment and care of patients with all forms of lung diseases cannot be overstated. It is my hope that in addition to the important research on prevention, diagnosis, treatment, infection control, and other innovations, that research on health systems also features prominently. A strong health system and a strengthened health workforce, and especially nursing workforce, will be critical to achieve the ambitious targets of WACI and end TB strategy, Sustainable Development Goals, and the TB-related targets arising from the UN high-level meeting on TB. Firstly, I'd like to emphasize the importance of strong health systems and universal health coverage when addressing TB and lung diseases. The definition of universal health coverage is sometimes misunderstood, but essentially it means that all people have access to the health services they need when and where they need them without financial hardship. So health services are equitable, accessible, affordable, and high quality. Universal health coverage includes the full range of essential health services from health promotion to prevention, treatment, rehabilitation, and palliative care. This full spectrum of health services is essential for patients suffering from lung diseases, including TB, as we know that a proportion of lung diseases can be prevented, and sadly, we also know that some patients will die due to their lung disease. Universal health coverage features in the End TB strategy as a key component of bold policies and supportive systems. Many of you will know that people generally approach health services for help with an undefined illness rather than visiting a clinic for specific care related to TB or any other lung disease. Therefore, access barriers to general health services must be removed. This requires a guarantee of full access for everyone to general health services, not just to disease-specific tests and treatments. Geographical and financial barriers for general health services use, such as out-of-pocket expenditure, must be minimized and systemic changes made to overcome these barriers. Furthermore, TB tests and treatment costs should continue to be fully free of charge, as has been the case in many, but not all countries. I encourage you to think more deeply about the role of universal health coverage in your setting and how this can positively impact your patients. With regards to universal health coverage, we know that currently at least half of the people in the world do not receive the health services they need, and about 100 million people are pushed into extreme poverty each year because of out-of-pocket spending on health. This deters people from accessing healthcare services, and it must change. The latest global TB report emphasizes that of the estimated 10 million cases that occur annually, about 2.9 million are missed, meaning that they are never diagnosed or treated. Surely the expansion of universal health coverage can help to close this unacceptable gap, while offering patients high-quality health care that does not cause financial catastrophe. WHO's global TB program, along with other partners, are committed to ensuring that every patient with TB can access high-quality care And in this regard, this year they have issued new guidelines on TB prevention, diagnosis and treatment, which also contains specific recommendations on patient support and decentralized healthcare services. And based on the latest global TB report released only a week ago, we know that more people are accessing TB treatment, another 100,000 cases in 2019 compared to 2018, and more people are also accessing preventative therapy, an increase of 1.9 million people between 2018 and 2019. These are pleasing results, but we can and should aim to do more. Nurses and other healthcare workers are a vital part of any healthcare system, including in the response to TB and in the expansion of universal health coverage. In 2020, nurses and other healthcare workers in many countries have been concerned with how they can rapidly mount an effective response to COVID-19. These healthcare workers are often the same ones who have been involved in the prevention and care of other communicable diseases, including TB. They bring the skills, experience and knowledge for managing other important diseases such as TB to the COVID-19 response, and in doing this, they demonstrate the fundamental importance of a skilled and agile national healthcare workforce in preventing and managing a range of communicable disease threats. WHO has designated 2020 as the International Year of the Nurse and the Midwife. The global TB response depends on the leadership and contributions of the nursing workforce, and TB nurses have been fundamentally important in linking people with TB symptoms to healthcare, detecting people with drug-resistant TB, and improving outcomes for TB patients and their families. The burden on infectious disease across the globe has been greatly reduced by vaccination, and nurses have and continue to play a key part in this effort. It is argued that the opportunity to discuss vaccination through personal contact with health professionals may support uptake, and that nurses who are often embedded in communities are therefore well placed to develop such initiatives. They play a vital role as patient advocates. Nurses have for long been involved in the management of tuberculosis, where their responsibilities have included case detection, treatment, enrollment and supervision, education, assessment of clients, social context, clinical treatment, psychosocial support to the client, counseling and motivation, facilitating socio-economic support for the client, and coordination of community care, including supervising community health workers and documenting clinical and programmatic information. The role of nurses has also ensured that multi-drug resistant tuberculosis treatment can be delivered at the community level. In South Africa, nurse-led mobile injection teams were found to be more cost-effective than treating multi-drug resistant tuberculosis at hospitals or clinics. While the contribution of nurses is sometimes overlooked, it cannot be overstated. In the International Year of the Nurse and the Midwife, this year WHO released the first stage of the world's nursing report. This landmark report reveals that there is much to celebrate about the nursing workforce. The report noted that opportunities for advanced nursing education and enhanced professional roles, including at the policy level, can drive improvements in population health. But at the same time, we continue to see vast inequities in the distribution of nurses around the world. This is something we must address. In fact, the report highlights that we need to create at least 6 million new nursing jobs by 2030, primarily in low and middle income countries, to offset the projected nursing shortages and to redress the inequitable distribution of nurses across the world. The report also recommends that the global public health community strengthen nurse leadership, both now and into the future, to ensure that nurses have an influential role in health policy formulation and decision-making, and contribute to the effectiveness of health and social care systems. Such investments are important in the 30 high TB burden countries and will also drive progress across the Sustainable Development Goals, the End TB strategy, and the targets set at the UN high-level meeting on TB. We do know that in 2018 and 2019, progress has been made towards reaching the targets of WHO's End TB strategy and the UN high-level meeting on TB. However, what is also clear is that greater efforts are needed, as the COVID-19 crisis had put existing gains at risk, and the gap between targets and results achieved to date remains large. While the participants at this conference discuss scientific advances to end TB and other lung diseases, think of the possibilities if those innovations were embedded into a strong health system with universal health coverage in place and additional highly trained nurses in adequate numbers who could deliver patient care and drive change at the policy level. This is not a utopian idea, but something we must actively strive for, even while we are in the midst of a pandemic. In fact, it may be more important than ever. Without nurses and healthcare workers, we cannot achieve health for all or end diseases like TB, which claim millions of lives each year. The World Health Organization is calling for your support to ensure that the nursing and midwifery workforces are strong enough to ensure that everyone, everywhere, gets the healthcare they need. I thank you.
Good day, folks. My name is Erika Mohr-Holland, and I'm working as the Rifampicin Tuberculosis Epidemiology Activity Manager for MSF based in Khayelitsha, South Africa. I have no conflicts of interest to declare. My speech today will be focused on the gaps in access to universal health care. What an interesting topic to discuss in the very unprecedented times we find ourselves in today. We are currently in the face of a horrific global pandemic with no end in sight. A great public health crisis which has placed massive pressure on the healthcare system and truly tested our healthcare providers. These challenges are felt even more so in places where people are subject to massive socioeconomic strain and hardship. But before I get into talking about the gaps in access to universal healthcare and how to tap those gaps, I would like to tell you a patient story. To set the context, Khayelitsha is a peri-urban informal settlement on the outskirts of Cape Town. It is home to approximately 500,000 individuals, the majority of whom live in informal housing units, and the average household income is $5 a day. TB and HIV are endemic to Khayelitsha, with a TB case notification rate of 1,600 per 100,000 yearly, and an HIV prevalence of 31% among women seeking care for antenatal services. And then the year of 2020 brought COVID-19. Patient X is a diabetic HIV-positive male, 58 years of age. He lives in a shack with 5 other people and is the sole breadwinner for his family. He develops a cough and shortness of breath and realizes that he has started to lose weight. He knows that there is an outbreak of COVID-19 and realizes that his symptoms are suggestive of so. He also knows that people with TB lose weight, so he questions whether he might have TB. He has noticed that people in the community have started stigmatizing the individuals who have gotten COVID-19. Some people have even been kicked out of their homes due to the stigma attached to a COVID-19 diagnosis. All over, it is a very challenging time in South Africa. As lockdown has been implemented, people are losing their jobs and not able to work, and people are getting turned away from healthcare facilities. Patient X is too scared to go to the clinic, having heard that some people presenting with cough are being stigmatized by providers, but also so scared of death as people in the community have been dying as a result of COVID. A few days later, not feeling any better, Patient X goes to his primary care facility where he's screened for COVID-19. He screens positive and is told that he must be tested for COVID. Despite expressing concern to the care providers that he is worried about TB, the provider tells him they're too busy at the clinic and do not have the staff available to test him for TB. 1 week after testing for COVID, Patient X tries to go back to the facility because he still hasn't gotten his test results. The providers yell at him for leaving home during the lockdown, but they do realize that they have his results on hand and inform him that he is COVID-19 negative. However, despite expressing that he's still feeling unwell, he is sent back home with no further medical management. 2 weeks later, Patient X's clinical state drastically deteriorates. He has extreme shortness of breath, his coughing has persisted, and he has lost even more weight. He is so weak that he cannot walk. His family members decide that they must escort him to the hospital. At the hospital, patient X is again screened for COVID and informed that he must be tested for TB. He is admitted, and 2 days later, patient X is informed that he does indeed have TB, and not only the small TB, but the big TB, resistant to most of the existing drugs. Unfortunately, 1 week after being admitted to the hospital, and 5 days after starting his TB treatment, patient X dies, leaving behind his 5 dependents. Patient X is only one example of the challenges faced by people in their journey to access primary healthcare services. There were plenty of opportunities to better manage and care for patient X, but all of these opportunities were missed. The system failed this poor man and continues to fail patients on a daily basis. One has to question what the cost of all these missed opportunities is. For patient X, it was his life. But if the system had managed to provide him with the services he was entitled to, would his fate have differed? How many times does the system have to keep failing people in order for there to be some real sustained change? We as public health specialists, medical providers, program managers, policymakers, we need to do better. We have all read the reports and the modeling studies. COVID-19 is estimated to lead to 6 million new TB cases and 1.4 million new TB deaths. Over the next 5 years, we might possibly observe a 20% increase in TB mortality. Additionally, it is estimated that COVID-19 will set us back 5 years in the progress made in the management and control of TB, which has already been painstakingly slow. One of my colleagues, both a TB survivor and advocate working in the field for over 15 years, recently said to me, "With TB, you struggle for 10 years. Take 1 step forward, and within 3 months of the onset of COVID, you take 20 steps backwards." So how do we tap the stark and prevailing gaps in the cascade of TB care in order to provide better care for our patients and ensure universal access to that care? In the advent of COVID, one might say we have had the opportunity to detect more TB cases, given the resources allocated to COVID surveillance and the overlapping symptom profiles of these two diseases. In South Africa, however, the number of TB samples sent for a test has decreased by 50% during COVID. Additionally, 3 million COVID tests have been performed, of which 10,000 included a same-day TB test. This means that only 3% of people access both a COVID and a TB test. The drop in TB testing is multifaceted. The messaging provided by the government was focused on accessing services if you were presumed to have COVID. Additionally, COVID stigma is crippling, and this was exacerbated by the lack of treatment available for COVID. Community members were scared of accessing healthcare services as a result of the stigma they might face from the community and care providers. Care providers during this time were also scared of COVID, and this might have impacted their decisions as to who they provided care to. This led to even less patient-centered care and the feeling amongst the community members that there was no one left to care for them. So keeping all of this in mind, I would like to bring you back to the topic of universal access to healthcare. What does universal access to healthcare actually mean? It is a term that we throw around a lot in the field of public health, but do we really have an idea of what we mean when we say this? The World Health Organization defines universal health coverage as ensuring that all people have access to the needed health services, including prevention, promotion, treatment, rehabilitation, and palliation of sufficient quality to be effective, while also ensuring that the use of these services does not expose the user to financial. When it comes to access to care for TB, we know that this is far from the reality. Every single day, over 4,000 people die from TB, and nearly 30,000 people fall ill with this disease. It is the leading infectious killer globally. In terms of TB diagnosis, the WHO tells us that we are only notifying 7 of the 10 million estimated TB cases. So why are there 3 million missing cases, and where are they? First, obtaining a TB diagnosis requires people to make it to the healthcare facility. There are many barriers to access to care, including stigma, a lack of education, one's socioeconomic status, and the ability to access services once at a healthcare facility. There's a lack of investment in health promotion. Even at the government level, TB is not talked about. More community engagement is needed in order to assist people in better understanding TB as a disease and the risks it poses to the community at large. National departments of health should consider more investment in health promotion and linkage officers. Second, obtaining a sputum sample to conduct a TB test is stigmatizing in and of itself. People under investigation for TB are forced to go to specific areas in order to cough and produce a sputum sample. This is not a confidential process and can lead to the stigmatization of that individual. Additionally, some people are not able to produce a sputum sample, making diagnosis even more challenging among such individuals. There is a need to have better means by which we can diagnose our patients to ensure that the process is confidential and patient-centered. Another known fact is that if people do make it to the facility, there are plenty of missed opportunities there. Screening algorithms are not followed or well implemented, and in fact, they are not sensitive enough. Continued training on the screening algorithms should be provided, and policy should consider endorsing more sensitive measures to detect TB. Treatment of TB. The World Health Organization reports that on average, only 1 in 3 people diagnosed with resistant forms of TB had access to treatment. Some people are lost or die before they even get a diagnosis, as our existing tests are not point of care. If there were rapid point of care tests that would allow for same-day initiation, this would assist in bridging the gap between diagnosis and treatment. For those who are actually initiated on treatment, there are numerous barriers to staying on treatment. These range from poor treatment literacy provided to patients and a lack of endorsement of counseling as a key role, the enormous social challenges faced by patients, including poverty, substance use, and food insecurity, the stigmatizing attitudes of providers, long and toxic regimens which cause unbearable side effects, the cost of drugs, and prohibitive national policies. These challenges are deep-rooted and multifaceted and involve those at the top levels down to the grassroots levels, and importantly, the patients themselves. The costs incurred during treatment are catastrophic, and thus innovative models of care that allow patients to access care while carrying on with normal daily activities are needed. Additionally, there is a dire need for timely service provision and non-stigmatizing care providers that deal with patients' needs in a holistic manner to ensure that they are able to address the challenges faced. Among the 85 and 56% of drug-sensitive and resistant patients who manage to get successfully treated, they are discharged from care without any consideration of the catastrophic costs incurred to make it through their treatment. Medically, they are viewed as a success, and thus there is no further investment in such individuals. However, TB is far from over, even if you have survived it. Such individuals go on to experience many further medical complications, including post-morbid lung conditions, post-traumatic stress disorder, and psychological challenges, and they face reduced quality of life. These people should not be forgotten by the healthcare system, but followed up routinely. Additionally, TB survivors should be engaged in high-level conversations and policymaking in order to share the lived experiences of those who have survived the harrowing journey in order to reform the quality of care given to patients. TB infections are estimated to increase as a result of COVID-19. TB preventative therapy becomes even more imperative. In fact, prior to COVID, there were exciting recommendations released by the World Health Organization regarding the treatment of tuberculosis infection. Post-exposure management has long been ignored and not prioritized or viewed as a priority service. But the cost of preventing one infection versus treating new infections has been proven numerous times to be enormous. Now is a great time to consider a renewed engagement and a broader scale rollout of the provision of preventative services. Engagement with community members in order to highlight the risks associated with TB exposure and the provision of treatment of infection in a family-friendly model of care is imperative to ensure that we can stop new infections. In finality, I would like to bring you back to patient X. He lacked access to a timely diagnosis and treatment. He did not have the best chance of being successfully treated as a result of these delays. His death left his family behind with the void of his absence and the catastrophic costs associated with his disease. In order to achieve universal access to healthcare at the grassroots level, we need to ensure that communities are engaged and educated about the diseases prevailing in their societies. We need to ensure that people are not stigmatized or denied access to services. We need patient-centered and differentiated models of care to ensure that the needs of individuals and their daily lives are taken into consideration, so that their disease does not become their life, but so that they can carry on with their life despite their disease, thus posing less cost constraints and restrictions on the individuals living with these diseases. We need investment in innovation and for existing resources to be better utilized. For example, community healthcare workers could be tasked not only to conduct TB screening at the household level, but to also assist in obtaining a sputum sample from presumptive TB cases at home. We need more accountability in the healthcare system. Staff should receive routine trainings to ensure that people are equipped with the best skills to carry out their work. Within the public sector, there are stark gaps between what is endorsed in policy versus what is actually practiced. Rather than providers triaging their work as to what they see as essential life-saving care versus a nice-to-have excess, all care should be considered as essential and provided as a comprehensive component of holistic care. COVID-19 has posed an opportunity to use the lessons learned to foster sustained change regarding the way we provide care. We need individuals' lives put first. We cannot afford any more missed opportunities or any more exorbitant costs. The time to act is now. Thank you very much.
Some of you might think, why am I here today? Let me answer that for you. You would have known the condition that millions like me live with, but you may not know what it feels like to live with a respiratory condition. You can see me, and you might think my condition is not visible, but so what? When I eat, when I sleep, when I walk, when I work, and even when I speak, I am mindful of my condition, but it does not define me. Chronic bronchitis and asthma have been my two constants in life, but I don't wish that for anyone else. Let me share some reasons for being so possessive about my conditions. My condition started early on when I was entering my adolescence. And the time was very difficult because I used to have breathless nights and frequent asthma incidences. But I was struggling with the fact to understand why was this happening. My outreach to healthcare system and healthcare providers only gave me an answer to an extent that I had some allergies and those got aggravated and I had to just look out for the allergies. But at a later stage, I discovered that my lungs also didn't feel too well when I used to go out for any sports. And then I headed back to the healthcare providers and asked them, why was this happening to me? And gradually, when I was around 13 or 14 years of age, I was told that I had chronic bronchitis and asthma came as a subsidiary to that. When life moved on, I tried to make lifestyle changes. I tried to cope with the condition and my family provided all the needed support. But there was stigma at school. There was stigma attached to the condition when I was in college, when I was looked down by my friends and they used to be very disappointed that I was not very active in outdoor activities. But that all came with my condition. I think it was important at that time that the role of nurses as well as healthcare providers gave me the strength that the condition was normal. They told me it was okay and I could deal with the condition, and that did give me a lot of strength. I would say that since then, since I was around 18 or 19 years of age, I could get in touch with other people who had similar conditions. And then I saw there was a strength in the community itself. During COVID, I think the strength of the community has even more strongly been demonstrated while we see that all of us come together and talk about our conditions and the restrictions in healthcare, accessing healthcare services, healthcare providers we have been facing, but still we feel that we give each other the much needed emotional support. You would agree that respiratory condition is not just a condition in itself, but is an outcome of a COVID-19 infection. And then you can imagine the stress and the fear that all of us with respiratory conditions have been living through during the COVID times. For example, the breakage of availability, I would say the challenges in accessing medicines in a timely manner while we were in national lockdown conditions really posed a challenge, while we were very afraid because we could not find access to, say, for example, an aspirin pump. And nights again were breathless. You're stressed. You already have the symptoms and you're confused. Is it because of a COVID infection, or is it your day-to-day symptom of chronic bronchitis? But I think we sailed through it, and it was all through the support that we got from our healthcare providers and as well as our families. For example, during COVID-19, the lack of healthcare provider availability, something that we witnessed and we are still struggling with that phase as of now, usually meant delay in diagnosis, which could be a challenge in leading a healthy life. And I would like to point it out that diagnosis in case of respiratory conditions is a challenge. And that's something that comes very strongly from my lived experience. I did struggle for 4 to 5 years to get the correct diagnosis. And during that time, it was just that I was being told by each and everyone that I had to learn and live with the condition. Whereas inside of me, I felt, this is just restricting my life. This is just restricting my capabilities. But there came a time after 5 years when I finally got the correct diagnosis. So in the case of respiratory conditions, I think it's very important that we stress on the importance of early diagnosis as well as screening, and the support, the palliative care support that is needed throughout the life. Palliative care is not just about end-of-life care, but especially in case of respiratory conditions, it is about easing the difficulties and the challenges that we deal with on a day-to-day basis. To build back better, there is a need to adopt a life course approach. Action needed from prevention to palliation. As a person living with a respiratory condition, I want to call out for universal health coverage through strengthening healthcare workers, prioritizing prevention, early diagnosis, and maintaining a continuous supply of essential medicines. I also want to reiterate the role of those living with these conditions in building a public narrative for lung health, and to take this opportunity to say, nothing about me without me. I leave you with this face, this smiling face, hoping that it gives you the reason, motivation, and strength to work towards respiratory health prioritization within the universal health coverage and sustainable development. Let's put people first. Thank you.
Welcome to this session. It is a moderated session of plenary 3, which is on striving for universal health coverage. I'm excited to moderate this session. My name is Rosemary Mburu. I work for WACI Health, which is an Africa regional advocacy organization. I'm delighted to be joined by 3 amazing panelists. We have Elizabeth Iro, who is the World Health Organization Chief Nursing Officer. Welcome, Elizabeth. We do have Erika Mohr-Holland. She is working with MSF based in South Africa. Welcome, Erika. And we have Ms. Prachi Kathuria. She is a person living with chronic bronchitis and currently working as a project manager, Healthy India Alliance. Welcome very much. So we've listened to your fantastic presentations, and I'll start with you, Elizabeth. First of all, congratulations on the State of World's Nursing Report. It's commendable to see that that report included a chapter on the role of nursing in 21st health systems. And your presentation has also now highlighted the role of nurses in making progress towards universal health coverage. So I think out of that, what we would like to hear from you is what is the most striking reflection that you might have around that for us as we get to closing this plenary 3 session. Welcome, Elizabeth.
Thank you very much, Rosemary. I think for me, the important thing out of that report is that this is a very first view of the global position of nurses. And it's the data and the evidence that that report has provided us with opportunities now to support countries in making the necessary policy changes in regards to education, regards to regulations, regards to practice, and also in regards to leadership. So for me, what this report has provided for us is highlighted that right now we have about 28 million nurses globally. But, there is a shortage of about 6 million. And 89% of this shortage is in low and lower middle income countries. So how we continue to deliver the services with this kind of forecast, it's really going to be a political, a economic, a clinical decision. So it's calling to the investment in nurses, an investment in leadership, an investment in jobs, in decent work conditions, and it's an investment in education. So I'm really pleased to see within this conference that we are able to see what more nurses are doing in terms of their contribution to universal health coverage, because they are very central and very critical to health promotion, to health preventative services, to treatment services, as well as to rehabilitation and palliative services. So nurses have a very key critical role to contribute to better health in regards to infectious diseases, in regards to tuberculosis, in regards to lung diseases. So I'm really pleased to kind of be able to bring this to the attention of participants, that we do require this investment in nurses, not just globally, but within regionally and also within countries. And so we look forward to that kind of support. Thank you very much.
Thank you so much for highlighting that, Elizabeth. And for me, one of the most striking things that have come across as we were preparing for this session is the realization that nurses are not only healthcare providers, but they are also advocates. So to see nurses as advocates, I think it's something that most people have not appreciated or have not actually understood. And we want to thank all the nurses and all healthcare professionals for the work they do as healthcare providers, but also as advocates. And that brings me to a question for you, Erika, because Elizabeth has highlighted the gap we have in nurses. And we do know we need to fill that gap if we're gonna make progress to universal health coverage. But I want to pick something from your presentation on the access and the gaps to access, which you have pointed and highlighted. What's your view, or what remark would you like to make out of that presentation and out of the point that even before COVID, we were already out of track to meeting the global goals? So now, what's your reflection on this, Erika?
Thank you so much for your question. So I think, as you have mentioned, it's very important that we take into consideration the progress that we've made, and in terms of working towards access to universal healthcare, and ensuring that COVID actually doesn't set us back in terms of achieving those goals, right? So if we look at COVID, and I think it has in a way highlighted a lot of gaps in access to universal healthcare, but it poses as an opportunity for us to learn further and take the lessons learned from programs that have well managed COVID in order to tackle some of those gaps. In my speech, I specifically talk about the gaps seen at the community level in terms of the management of drug-resistant TB and COVID. And I think a lot of the times, one of the biggest gaps in terms of people accessing care comes down to the community. And I think if we engage communities and ensure that there's good health promotion, that communities are engaged and aware of the risks of the diseases that are prevailing in their societies, that's one way that we can ensure that people are not empowered to be able to seek out the care that they are deserving of. But I think also we know that there's a big gap in terms of what's actually endorsed in policy and what's implemented on the ground. So I think it's really important for policymakers to also work with those communities to ensure that we are tapping those gaps in terms of knowledge and education, but also working with the healthcare providers on the ground to ensure that people are continually motivated to provide the services to the communities in need, to make sure that people are educated, to make sure that the services are brought to the community members. I think a lot of the times some of the challenges are that community members or the people living with diseases are the ones that are expected to seek out those services rather than healthcare providers bringing those services to the community level. So with that in mind, and with the role of nurses in tapping gaps to universal access to healthcare, I think it's important and very imperative that we as care providers think about innovative models of care in which nurses can be used to bring services to the community at the community level, so that we ensure that people are indeed actually getting a diagnosis, and from there we look at the further gaps in terms of getting treatment. Nurses can be providing and supporting patients in more facilitative, patient-centered models of care to ensure that people, once diagnosed with a condition, are able to stay on their treatment and get a successful outcome. So yeah, I think from my side, those would be some of the key points. Thank you so much.
Thank you so much, Erika. It's quite interesting, the interconnectedness of the issues you're all bringing, because you have now pointed to a very important issue around community engagement, community participation in accountability. And we do know that one of the things I always say is that no global health response will be won without communities. And we know it is either won or lost at the community level. But now, it's very interesting because we are saying communities won't access health services unless health systems are strengthened. Health systems won't be strong unless we have enough nurses to actually do the work that needs to be done. And so that brings me to you, Prachi, as a community representative, as a civil society representative. First of all, thank you so much for sharing with us your personal story. I think for me, it's an indication of the need for empowered communities, like Erika is saying, so that communities can participate in decision-making, can hold governments accountable, and we can make sure that we reach the last person. So given your personal experience, what would you like to highlight as far as striving to universal health coverage is concerned? Prachi.
Thank you, Rosemary, for the question. The personal story that I built upon in my presentation, it is about the challenges that a person with a condition, a respiratory condition, deals with day in and day out, starting from the day when the condition is not even diagnosed. I mean, it comes at a later stage, whereas you are struggling with the condition already. And by the time you have recognized that there is a problem and you reach out to the health system, it might so happen that, especially in cases of chronic bronchitis or asthma, you are the diagnosis process itself is delayed. So I would say that for a person living with an NCD or a respiratory condition, a chronic bronchitis, in my case, universal health coverage is particularly important. For example, the abrupt unavailability of asthma medicine could cause severe suffering and even death. Especially, we have seen that access to medicine and healthcare has been a challenge during the COVID-19 pandemic. We have been struggling in terms of dealing with our symptom. A respiratory condition or breathlessness, for example, is not just an outcome of a COVID-19 infection, but in itself is a condition, is a respiratory condition. And in that case, while we were having restricted access to healthcare providers, there were a lot of questions that were there in the mind of I would say for all of us who are living with a respiratory condition. So universal healthcare action for a person living with a respiratory condition would essentially call out for action through strengthening healthcare workers, their important role in not just helping diagnose a condition, but also the whole concept of palliative care and giving that strength and support to those who are dealing with these conditions and making their life easier, I would say. And it's at times it's important for somebody to come up to you and say, it's okay, we're there for you. That makes a lot of difference. Then prioritizing prevention, early diagnosis is key to respiratory conditions, and maintaining a continuous supply of essential medicines. I also want to reiterate the role of those living with respiratory conditions in developing a public narrative for lung health. And I will take this opportunity to reiterate the statement, nothing about me without me. Any decision that is taken affects me as a person who's living with a condition, with a respiratory condition. And I don't think any policy, any program, or any universal health coverage intervention is complete until and unless I'm a part of the process of planning, programming, as well as implementing a strategy, be it at a national level or subnational level. Three key takeaway messages that I would like to highlight, and then I give it over to you, Rosemary, is that we improve early diagnosis of respiratory conditions. That's key, that's critical, and I have highlighted that in my personal story as well. And this can be done by increasing public awareness of lung health and diseases. And again, the role of those who are already living with this condition is immense here, and we need to recognize that. Second is that we promote universal access to quality health care, essential medicines, and immunization, especially during public health emergencies like we are dealing with, and we are in a public health emergency right now. And we also parallelly integrate palliative care as an essential component while we talk about the role of nurses here, because the warmth, I would say, that you receive from them really gives you strength. And the third point is standardizing the monitoring and management of respiratory conditions with evidence-based national and international strategies. And we can learn from successes, from best practices that are being implemented in other countries, and to derive strength from those. I think these are the three takeaway messages from my side. And thank you very much for your question, Rosemary.
Thank you. Thank you so much, Prachi. You highlight really great elements of health system strengthening, that we cannot just address TB, we cannot just address HIV or malaria, but I think you are calling us to think about a more integrated approach of ensuring that we actually factor in a host of elements that go into ensuring that we make progress towards universal health coverage and actually make progress towards achieving the Sustainable Development Goals. Given that we are really getting close to time, I would like to invite each one of you to give a quick final reflection on this particular topic. What's your message and your concluding remark that you'd like to give? I'll start with you, Elizabeth, then turn to Erika, and then Prachi. Welcome.
I think for me, Rosemary, my final message is really that this is a whole systems approach that we need to be considering, not just a single focus approach to ensuring health for all, and it applies to all communicable diseases, it applies to all lung diseases. So we need to be people-centered, with one approach to strengthening health systems. I think that's my message, I think, for this session. And nursing is one of those components that really needs strengthening, because they are the closest to the communities and to the people within the communities, wherever they may be. So I think that's really critical. So that's kind of my final message to contribute. Thank you very much.
Thank you. Erika?
Hi, thank you so much. So I think in conclusion, I'd just like to reflect on that it's important that we consider the individuals that are affected by these conditions, and that when providing care for these people, it's important that we ensure that we're providing care in a comprehensive and holistic manner. And I think that keeping that in mind, it's really important that we act now so we don't have any more missed opportunities in terms of the provision of healthcare or access to healthcare, which unfortunately is happening at the community level a lot. So I do think it's important that we look at access to universal healthcare in a comprehensive and holistic manner, and always to remember the individual and ensuring that we're providing care in a patient-centered manner. Thanks so much.
Thank you. Prachi?
I would again go back to the statement that I was making, nothing about me without me. Universal health coverage mandates to leave no one behind, and lung health needs to be a priority while delivering universal health coverage interventions, because it's I would say it's an invisible condition. It's not there. But the impact of it really affects a person and the life that they need. So nothing about me without me.
Thank you so much. It's been lovely having this conversation and hearing the different insights and perspectives that go towards making progress towards universal health coverage. Thank you very much.